The theme of today's webinar is kidney transplantation and living donation. There are more than 4,500 Canadians waiting for a transplant, of which more than 75% are waiting for a kidney. Next week, we celebrate National Organ and Tissue Donation Awareness Week, also known as NOTDAW Week. NOTDAW raises awareness about the critical need for more donors across the country and encourages Canadians to register their decision and to talk to their loved ones about organ donation. I would now like to introduce our speakers. Dr. Gill is Professor of Medicine with tenure at the University of British Columbia, Division of Nephrology, St. Paul's Hospital. John completed his medical training in 2000 and completed a master's degree in clinical research at Tufts University in Boston before joining the Division of Nephrology at UBC. John is an active researcher whose interest includes clinical outcomes in kidney transplantation, access to care, clinical trials, and health services research. He has published 200 peer-reviewed manuscripts and has peer-reviewed research support through his career. John is a deputy editor of the American Journal of Transplantation and counselor at large of the American Society of Transplantation Board of Directors. Our next speaker is Sylvie Charbonneau, is co-founder of consulting company Brio Change, a professor in the Department of Executive Education at HEC Montreal, and a member of the board of directors of the Quebec chapter of ACMP, Association of Change Management Professionals, an international association of more than 3,000 members around the world. She has also served on the executive committee of the Kidney Foundation of Canada, Quebec branch. Sylvie will share her experience donating a kidney to her son on December 6, 2012, as well as her dream to change the world one kidney at a time. And now I'll pass it to Dr. Gill.
Well, thank you very much. It's a real pleasure to be able to share this time with you all. You know, this is a special time of year for organ donation, and I think things have been obviously acutely in the public eye, given the tragedy in Saskatchewan and increased emphasis on organ donation as a result of that. I'm also happy to be able to share this presentation with Sylvie, who's actually donated a kidney. So without further ado, I'm going to advance to my first slide, as long as I can get that to work. Try that again. There we go. This is just an overview of what I'll be speaking about. We'll first review deceased and living organ donation activity in Canada, and then we'll talk about some innovations in Canada and internationally to increase organ donation, both from deceased and living donors. So this is 2016 data for Canada, which first shows you the number of deceased organ donors in the country. And it presents this, so basically over the last 16 years. And the total donors are in the dark blue. And you can see that there's been a positive upswing year over year, really since 2010. And much of this upswing has been due to an increase in so-called DCD donors, which are shown in green. These are donation after circulatory death donors. And this is a donor who has suffered a devastating and irreversible brain injury and may be near death, but does not meet the legal criteria for neurological brain death. And in these cases, the family has decided to withdraw care and to then proceed with organ donation after the withdrawal of care. If we try and benchmark the activity in deceased organ donation, the most common way that this is done is by referring to it in terms of the donor population. So you get a deceased donor rate per million population. So we have about 35 million people in Canada, so it's benchmarked to that denominator. Now, this is used internationally to compare organ donation between different countries, but importantly, it has some limitations. As you can imagine, there are significant differences in death rates among persons within a country who may be eligible to be organ donors. So it's not a perfect metric, but it still is the most widely used metric internationally. And again, you can see that there has been improvement. 2016 is not included on this slide, but it's hovering right around 20 per million in 2016. And so you see on a population level, which takes into account differences in death rates between countries, you also see this upswing in deceased organ donation. Now, this slide has a lot of information on it, but if you just take a second to look at it, it shows Canada in the top row, and then each of the regions in the country in the first column. And you get a picture of the donor rate per million as a function of time. And what you can see is in the top row, what we also saw in Canada is an upswing in the recent activity since 2010. But the other important thing here to note is that there is significant regional variation in organ donation between different parts of the country. And if you look at this, you can see that in general, the prairie provinces are a little bit lower. There is strong activity with regards to organ donation historically in Quebec, and that persists throughout this entire time period. You also see strong organ donation in the province of Ontario and in British Columbia. But I'd highlight that the other thing that is on this slide is that there are changes over time. And importantly, BC has shown significant increases in deceased organ donation in more recent years, where we're now in BC, we have a donor rate over 20 per million. This next slide shows you the actual number of deceased donors in the dark blue, and now the number of living donors in the lighter color. And you can see that the number of living donors in particular has been relatively flat over the last few years, where you can see that in recent years there has been an increase in deceased donor activity. This next slide shows that same breakdown for living and deceased donors, but now it's benchmarking it in terms of the donor rate per million. And now you can see that I think it's important to highlight here that the caveats I gave you with regards to the donor rate per million for deceased donors really don't apply for the living donor situation. And this is because when you're looking at a living donor rate per million, you're actually capturing donors from living persons among a living population. And therefore, it's not subject to the variation in death rates that I talked about before. So in the living donor situation, the donor rate per million is a very accurate estimate of activity. And again, here you can see that in the lighter blue in the last few years in Canada, things have not increased with regards to living donation in the country. This next slide has got a lot of ups and downs in it, but the point here is to show you that there is regional variation in living donation across the country. And importantly, when we compare the variation in living donation compared to deceased donation, there's much more variation regionally with regards to living donation. Here, if we can just highlight some activities in different regions, you can see BC is high with regards to living donation, has been throughout this period of time, as is Ontario. And in contrast, when we look at Quebec, which, if you recall from the deceased donor slide, had a very high level of activity, here it has a low level of activity of 6.7 per million. And similarly, in the previous, when we were looking at the deceased donation, I highlighted that the prairie provinces were a little bit lower, but here you see that Alberta has relatively high activity with regards to living donation. So the important points here are there is regional variation, and it's bigger than what we see for deceased donation. Now, when we look at this, I think the opening comments did highlight the fact that although there has been some positive aspects of donation, the need is still overwhelming. And here you can see the number of patients waiting for a kidney transplant. And it's important to know that although this list looks relatively flat over time, so it's not, going up exponentially over time, the waiting list in Canada is not really an accurate indicator of the actual need for kidney transplantation in this country. And that's because the number of patients who are actually on the active waiting list is not necessarily representative of all those who are candidates for a transplant. And then we also know that there's many patients on dialysis who have not yet been referred or activated to a waiting list. And so it doesn't accurately reflect this, because someone may look at this graph and say, well, things aren't getting worse over time. And that's not the message that is obviously accurate. Maybe a better way to get a sense of the fact that there is a huge supply shortage, this gap between the supply of kidneys and the need for kidney transplantation is maybe encompassed here a little better. And this actually shows you the time that patients who actually got a transplant had to wait. So it's the median time, or what that means is 50% of the patients actually waited longer than this time and 50% of them waited less than this time. But it gives you a sense of how long patients are waiting. And so overall, you can see it's 1,468 days. And of course, biology plays a role here, where there's significant difference in waiting time as a function of blood group. Now, I'm going to turn with that sort of thumbnail overview of activity in Canada to talk about some innovations. And the only deceased donor innovation I'm going to talk about in Canada that's relevant is really one of increasing access for highly sensitized patients, or the so-called highly sensitized program. And this slide, I just put in as a placeholder to explain this a little bit. So the HSP program is for patients who are considered sensitized because of exposure to foreign non-self tissue. And this is either because of pregnancy, previous blood transfusions, or previous transplant events. And this is measured by something called the CPRA, which is measured on a continuous scale from 0 up to 100. And patients who have a high CPRA, this means that these patients would be expected to reject a high proportion of organs from donors in their donor pool. So the HSP program is designed to increase access for transplantation for these highly sensitized patients by allowing them to receive a kidney that they will not reject if it becomes available anywhere in Canada. So normally for patients with a CPRA of less than 95%, they're only eligible to receive organs from organ donors in their province. So this is really an effort to increase access to organs from anywhere in Canada for people who otherwise would have a very low chance of getting a transplant. And this slide just shows you the activity in the program really in the first 12 months of its launch. And the important thing here is just to focus on the HSP patients that received a transplant. And you can see that in the first year here, there were 72 such patients, but you can see that the number of such patients, this is for the whole nation, that are actively waiting is well over 400, with some of them being active on the list and some of them actually being removed off the list. But since this program has taken off, it's actually really increased access for these patients who otherwise really would have very little hope of getting a transplant, because the organ supply within their province, and you can appreciate that some of our provinces have relatively small donor populations, their chance of getting a transplant otherwise that they wouldn't reject would be very low. The next innovation that I want to talk about, and where I'm going to focus most of my comments, is with regards to living donation. And the specific thing I'm going to talk about is this thing called KPD, which stands for kidney paired donation. And as shown on this slide, this involves swapping of kidneys between donor and recipient pairs who are incompatible to donate directly. So in the top, you can see there's a blood type A donor. They can't donate to their blood type O recipient. And in the bottom, you can see there's a blood type O donor who's actually a universal donor from an ABO blood group perspective, but there's a positive cross match with their recipient. And in this simple scenario, the donors simply swap kidneys and both recipients receive transplants. So that's in its simplest concept. This next slide shows what we call a domino, and these can go here. I'm just showing a two-way domino, but it could be a longer one. And importantly, what happens here is these sort of mini dominoes are started by an NDD, which is really an anonymous donor. So somebody who decides to donate a kidney to anybody on the waiting list. And the way this works is we use those organs with the approval of the donor to trigger these chains where the last kidney from the last living donor actually goes to somebody on the waiting list. And these chains are usually done simultaneously, but you can see that they can also be what we call non-simultaneous. So there can be a period of waiting in between where you assemble another group of patients and donors that you can help by holding this donor back. And so these things can actually be quite perpetuating and go on for some time, which is shown here in the so-called non-simultaneous chain. Now, there's always a chance. We don't do these 9 simultaneous chains in Canada. We try to do all of the transplants in a relatively short period of time. We try for them to be simultaneous, either usually on the same day, and sometimes spanning over a couple of days because of logistical concerns, because you imagine we're a big country with many time zones. And so these transplants are happening in multiple transplant centers. But there is a small risk of making a donor whose recipient has already received a kidney to wait. And there have been cases where donors, for a variety of reasons, don't proceed with organ donation. And that, of course, is something you obviously want to avoid. Now, this program is, I think, a real success story. It was really driven by members of the Canadian Society of Transplantation coming together to make this happen across all jurisdictions and facilitated by Canadian Blood Services, which helped really establish the infrastructure and maintains the data system. So it really was one of the few examples of interprovincial cooperation in this country with regards to healthcare. And you can see here that we've now done about 5, if you add all the numbers up, it's around 500 such transplants. We've exceeded that number now. But importantly, you can see in recent years, we're not continuing to grow here exponentially. And this is obviously something that I'll talk about a little bit more, but it's a concern. So we've definitely done something good here, but we need to think about how we continue to increase this activity. And I just added on here in the 2012 data, there was 86 such transplants. So a positive number, but not a giant increase. If you look at the details of the types of these transplants that are actually done, you can see that there's a heavy reliance on these domino chains, which means that we're heavily reliant on anonymous donors to trigger these chains. And you can see that there was 89 dominoes. That means there was 89 anonymous donors during this time frame. Now, you can see here that there is also regional variation in the use of kidney paired donation. So obviously, if your province isn't registering patients in this program, you're not going to receive a transplant through this program. And you can see that, as we saw before, the areas that tend to have strong rates of living donation are also the ones that are strongly participating in this program. This is probably the most complicated slide that I'm going to show you, but it shows you which patients are not being served by this program. And It's the patients who are the hardest to transplant, those with high CPRAs, which are shown in that kind of maroon color at the top of the screen. You can see that these patients accumulate over time in the program, just because even with this swapping, these patients are still very, very hard to match. And so those patients are left behind, and some of them have been in there in the program since 2009. So it's a giant advance, but it's still not meeting all of our needs. Now, one of the ways that we're talking about trying to increase activity in this program is by using so-called compatible pairs. So these are individuals who don't need to go in the swap because they are actually, the donor is actually compatible with their recipient. And you can see this highlighted on the bottom of this screen, where the donor 1 is actually compatible with recipient 1, but they choose to go into this program so that they can help somebody else. And this is definitely a new way of thinking about living donation, which tended to be a very private interaction between people who were emotionally related. This is an actual example of this. This is well published in the literature. A 67-year-old ex-president of Notre Dame University was compatible with his 42-year-old nephew. On the flip side, in the same program, there was a 38-year-old male who wanted to donate to his mother, but there was an incompatibility issue with blood group. So what ended up happening is they swapped kidneys, and in return, the 42-year-old recipient received a kidney from a much younger donor than they otherwise would have. Now, one of the reasons I showed you the accumulation of highly sensitized patients in the kidney pair donation program, the other issue here is there's an imbalance of blood type O. And the basic message of this slide is there's more patients who are blood type O than there are donors of blood type O in KPD programs. So blood type O recipients also accumulate in these programs. So why would a compatible pair want to consider doing this? Well, like we saw in our example, the recipient might receive a younger donor kidney back. They might also get maybe a bigger kidney, a better size match kidney, or a better matched kidney. Or it could be simply an altruistic donation decision where the donor and the recipient want to help more people if they can. And what does the incompatible donor pair gain? Well, obviously they get higher match rates, and we know that this also increases access for recipients who are blood type O. Now, we actually performed a survey of previous living donors in British Columbia, and this was published. And what it showed is that people who had previously donated a kidney were overwhelmingly supportive of doing this, being a compatible pair if it had been available to them. So retrospectively, when you go back and ask donors, they say, absolutely, this is something we would strongly consider. When you drill down, there were some important caveats, though, that were important. The take-home messages here is that obviously this would be more strongly considered if there was a potential advantage to the recipient. The second case is the donors in particular wanted to make sure that their recipients were on board with them doing this. And probably the most important thing is that they didn't want to delay transplantation for their loved one who they could otherwise donate directly to. So there are consensus recommendations which are not applied in Canada, despite this being written in 2013, that all potential living donors should be informed of their ability to participate in KPD, even if they are compatible with the person that they initially presented with the intention of donating. So if we look at these potential advantages to the recipient that the recipient might get by going into a KPD program, there's donor age, there's maybe a bigger kidney, and maybe there's a better HLA match. The important thing about this is it's hard for clinicians to sometimes quantify the benefit of some of these things in terms of long-term outcomes. So although I think a 40-year-old donor kidney might do better than a 50-year-old donor kidney, being able to really quantify that given everything else that can happen after transplant can be a little bit hard. The other thing is my ability to guarantee that benefit will be actually recognized is obviously not perfect. And then also this has the potential to delay the transplant for the compatible pair, because if we have to make them wait until we find a pair that they can swap with where they will get some advantage, it could lead to missed opportunities for transplantation. So the crux of this is that we would like to advance a strategy that would get compatible pairs more interested in participating in this. If there was a benefit that could be provided or to them at the time that they would consider going into the program, and it wouldn't delay transplantation. So what is this concept? It's a concept of reciprocity. So basically, if a recipient who doesn't need to go into this program with their compatible pair, if their kidney were to fail in the future and they needed a second transplant, they would be given some priority for a second transplant from a deceased donor in the event that their primary kidney transplant failed. And how would you operationalize this? Well, we know norms of how long living donor kidneys should last. And based on the deficit that might be encompassed, there would be presumably a point system. So the details haven't been hammered out. This is still a concept. And this would be provided irrespective of other benefits that the recipient might have gotten. So if they got a slightly younger donor kidney or whatever, they would still get this benefit. So the advantage of this is that it can be well quantified, that people can understand what the benefit is. You can offer it with surety, and it doesn't delay the transplantation, unlike those other potential benefits. Now, this concept has been used in Israel, where they have provided priority for transplantation for individuals who've registered as a deceased organ donation, but also people who have donated a kidney as a living donor. So I won't go into the details of that, but suffice to say, this has been shown, this principle of reciprocity has had an impact in other countries. What about harming people on the waiting list? And we don't really think this is a significant issue, because if you think about it, if you do a living donor transplant today, you're actually removing somebody from the waiting list, which increases opportunities for people who don't have a living donor on the waiting list. The other issue is we know the number of living donors who are likely to fail and come back to receive some priority is going to be small. And so we don't think this is a big threat to people on the waiting list. We've actually quantified that. So we've done simulations to show that if you increase this, you're unlikely to harm people on the waiting list in terms of waiting time, and that publication is shown here. So where are we with regards to this? I know I've gone a little bit over. We're advancing the following. We're looking at this from a legal perspective. We want to prospectively survey living donors because we've only asked previous living donors. We also want to get the opinion of patients who could be conceivably impacted by this. So patients who are on the waiting list who do not have any living donors. And then finally, we want to think about examining additional strategies. So as you know, living donors, there is a small risk that they themselves could require a transplant at some point in the future. And right now, the safety net for such individuals is that they go to the top of the deceased donor waiting list. One issue that has been seriously considered and it has been operationalized in some jurisdictions in the US is that if a living donor failed in the setting of a compatible pair participation, they could be prioritized for a living donor from the system. That would be an anonymous donor's kidney. So these are moving points where we're trying to enhance living donation. So I'll stop there and turn it over to Sylvie.
Thank you, Dr. Gill. Good afternoon, everyone. So my piece will be, I'm going to tell you a little bit about our family story, which started some years ago already. So I have 2 kids. So these pictures are from quite a while. So I've been married for over 40 years, and I have 2 kids and 2 grandkids. And those here are my husband and my 2 kids when they were younger. My husband and I have always said that we were very lucky in life because we had very healthy kids. We had a great family. We were doing a lot of things together. Our 2 kids were into sports mainly. They were swimmers. They were competing in swimming. Even as teenagers, there were not a lot of trouble because they were spending so much time in the pool that they didn't really have time to do anything else than go to school and swim. We thought that we were lucky, they were healthy, and we were, and we are still, I think, a great family. I'm going to talk to you more specifically about our son, Benoit. This is Benoit when he was about 23 years old, so that's about 12 years ago. This is at our daughter's wedding. Benoit was just out of university. He studied in management and technology. He was full of hope. He was still swimming. He had a great group of friends. And as you can see, he's quite a handsome man, I think. And I tend to say that he looks like his mom. So there you go. We were very, very happy and very lucky. Some years after that picture was taken, Benoit came home one night and he told us, my husband and I, well, I was not feeling very well, and I just went to the hospital, to the emergency room to have myself examined because I really had some pain and some belly pains, and I was wondering if, I hurt myself doing in swimming, or he was also into water polo. So he went to the hospital, and they kept him. They did some blood tests, and they discovered that both his kidney were functioning only at 25%. He was 27 at the time. So this was like a shock for us because you might know that, but kidney disease is a very silent disease. You don't know that you have something until it's probably too late. So we were like in shock. So we said, okay, so what's happening? What's next? What's going to happen to you? And he told us, well, I'm going to have a very severe diet. And I'm going to have to be very, very careful about everything I eat. Just to give you an example, Benoit is 6'1". He's 180 pounds. And in his diet, he had 5 pages of restrictions of things that he was not allowed to eat, or that he was not allowed to eat only in a very specific quantity. An example of that is any source of protein. He was allowed to eat 7 ounces of protein per day, which means that if you have a normal chicken piece of meat for lunch, there goes your protein for the whole day. So the rest of the meals, the breakfast and dinner, had to be without any protein. So diet was very, very difficult for him. First, because he was still a lot into sports. He was still swimming and playing water polo 3-4 times a week. He was working full time. A 27-year-old man goes out with his friends once in a while. So that was very, very tough for him. At one point in time, we were hit with a very shocking, I should say, catastrophic event. Could have been catastrophic event, I should say. Benoit called us. My husband and I were attending an event at night, on a Friday night, and he called to say, I'm in the hospital. My nephrologist called me this morning, and he told me that my potassium level was so high that I was in danger of having a heart failure. So I'm now in the hospital, and I'm going to have to go through some treatment, and if that doesn't work, well, they're going to put me into dialysis. And it was like, for us, it was a big eye-opener. It's as if we all together as a family realized at that moment that he was in danger. He was really in danger. I mean, when you're 28 and you get a call, get into the hospital, because if you don't, if we don't clean your blood, you may die. I mean, when you're 28, you don't think you should receive such a phone call, and you don't think such a thing should happen to you. And I can tell you, as a parent, it has been a shock. I mean, I still see myself. I still remember where I was when we got that phone call. So for us, that was reality check. And Benoit even came more aware of everything he had to be careful about his diet. So yes, sodium is one thing that you have to be very careful about, but potassium is something that you have to avoid as much as possible. And there's potassium in almost everything you eat. I mean, bananas, potatoes, tomatoes, avocados, salmon. There's potassium in almost everything you eat. So Benoit became even more careful about what he was eating, to a point where whenever he would go somewhere and he would eat something that he had not prepared or I had not prepared, he was getting anxious. Let me give you an example of that. I remember one day we went to a restaurant for a Father's Day brunch with my father-in-law, and Benoit ordered a plate. He mentioned to the server, to the waiter, I cannot eat this, I cannot eat that. There was some rice in the menu, and he said, it has to be plain white rice, no tomato in it. And the waiter said, don't worry, it's plain rice. When the plate came, the rice was full of tomatoes. So he just left it aside. But just that made him aware that there might be other things in his plate that he was not aware of. And so he started eating. And just after a few bites, he just looked at me and he said, I'm not feeling well. I'm really not feeling well. I think we should go to the hospital. And finally, we said, okay, let's go. And we left the restaurant. And after about 20 minutes, when we were on the road, he said, you know what? I think I'm okay. I was so anxious that I guess I just had a panic attack. So that was his life. I mean, you're 28, 29, that was his life. So at the very beginning of this whole adventure, I raised my hand and I said, I know that you can give a kidney while you're alive, so is there anything I can do to help you in there? And I got connected to the kidney transplant department in the hospital where we live, and I started my process. Meanwhile, Benoit did, as I said, drastic changes to his diet, but he was also getting weaker and weaker. So he had to stop his sports. So his nephrologist told him, if we don't get a donor for you soon, we're going to have to put you on dialysis. And meanwhile, if you want to keep your energy, if you want to keep working, you'll have to stop your sports. So again, he was very careful, very strict on his diet, and he stopped his water polo, and at one point in time, he stopped his swimming as well. One thing he didn't do is he didn't talk about it. He was, I don't know what word to use. I wouldn't say embarrassed. I think he was unhappy with the fact that when you're 28, 29, your body shouldn't abandon you. And he didn't want to feel the pity of people. So he went to work, went to his water polo practices, and went to his swimming practices, saying nothing. Nobody around him except 2 or 3 of his closest friends and our close family knew about what he was going through. So meanwhile, I started to, my husband and I raised our hand and said, we want to see if we can be living donors. And we started the process, the both of us. We were luckily both compatible because if you remember about the statistics that Dr. Gill showed you, the longest waiting period on the deceased donor list is type B, the blood type B, and my son is type B. My husband is type B, and I'm type O. So we both went through the first stages of the test. We were both compatible. But at one point in time, my kidney health were better than my husband's. So I continued and I went through the whole process. Our daughter, who's 2 years younger than our son, also raised her hand. And she said, you know what, if you're not able to go through the whole process, because you have to be in perfect health to give a kidney. So our daughter said, you know, if it doesn't work for the both of you, I will try to be a living donor. And my reaction was the reaction, I guess, of a mom. I just looked at her and I said, no, I cannot do this. I was unable to picture myself having both my kids in surgery at the same time. And then I realized that while I was saying this is what I was asking from my husband and my daughter. My husband had to accept that both his wife and his son, and my daughter had to accept that both her mom and her brother would be in surgery at the same time. And the reason why I'm bringing this to the table today is because it's really a family choice. You know, at first I just rose my hand and I said, I want to be a living donor. But there are impacts on people around you, and you have to make it a strong and happy story. You have to make it a family story. It's really a family choice. At least in our case, it was a family choice. We went through this all together. It's been 5 years now. Benoit is doing well so far. And I know as a mom, whenever he calls and he says that he's not feeling well, I always have that question in my mind. Is he only sick because he has a cold, or is he sick because his kidney is abandoning him, or his disease is coming back? So to me, this will always be a question that I'll have in my mind, because even though, you know, life is way much better with a kidney transplant than being on dialysis, it's not a forever solution. There is a living time period for a kidney transplant. But so far, so good. So we take it one day at a time. For Benoit, it has changed his life drastically. After a few months, he was back in the pool. He was back with his friends. And actually, if I just open the parenthesis on that, he had to tell his friends that he was going into surgery, because a few days before we got the surgery, our story was the front page of our local newspaper here. So he knew that his friends would read about the story. So he sat down with one of his friends and he said, you know, I'm not going to the water polo practice anymore, not because I got an injury, it's because I'm sick. And the guy was so shocked. He said, well, why didn't you talk about it? And he said, I didn't want to feel your pity. I didn't want you to be worried about me. So now I'm going through surgery and I should be better. Today, Benoit is doing very well, as I mentioned. Benoit is now an ambassador of transplant of any kind. He, in 2015, after his transplant, his goal was to go back into the pool, go back to swimming, go back to competition. And his motivation was the World Transplant Games. So he attended the World Transplant Game in Argentina in 2015. and he came back with 5 medals, 2 of those gold medals, and a world record. And so for him, that was a tremendous push of energy, if I can say that. But most out of that was he met at those games, he met guys his own age who were practicing the same sport, had the same issue with medication, diet. He felt connected with people who had been through the same thing as he had. So he felt part of a group again. He didn't feel isolated anymore. He was able to talk about his disease. He was able to talk about his medication. He was able to talk about his training, sometimes how he felt tired. To him, it was like, he said something during that week at the World Transplant Games to my husband and I. He said, you know, there's only one person who had a kidney disease and went through a transplant who can understand another one. So to me, that meant even though we were very close, we haven't gone through everything he had gone. So for him, that was, it was a turning point, I think, after his transplantation. He also participated in Malaga. So this is one of his, well, this is a picture from Argentina with all his medals, and the guy beside him is another guy from Quebec. Actually, they were working in the same company. They didn't know they had that both had kidney transplant. They knew about it when they met at the games in Argentina. So incredibly, they were both guys from Bombardier in Montreal. They worked in the same building, and that's where they met. So last summer, he went back to the games in Malaga. He came back with 3 medals. But for the first time, the living donors and family representative of deceased donor were allowed to participate in the games. So he said, Mom, are you going to do this with me? And I accepted the challenge. So over the last, in preparation for the games, I started back jogging, swimming. I lost 25 pounds. I didn't come back with any medals, but I can tell you that I came back with a lot of motivation. I came back, I think, healthier than I've ever been in the last 25 years. And all of that because one day my son got sick. I decided to help him. He got better. He went to the games. And when I saw all these people who've been through so much training and pushing hard to stay healthy and to say thank you to life and thank you for my health again, I thought, why not me also? So I'm not in the picture, but I was part of the games, and it was a great motivation. Benoit will participate in the next Canadian Games in Vancouver next summer, end of June. And again, it's, you know, we're taking it one day, 1 week, 1 month at a time. We know that one day might come where Benoit will need another transplant, but thank you for the research and people like Dr. Gill who are looking into what can be done to push that date as far away as possible. So that whole story made me wondering how I could help. So I got involved with the Kidney Foundation the year after we got the transplant. I started by being a volunteer at our Montreal walk. After that, I became a member of the board of directors. I participated in a lot of fundraising activities. Anytime I can talk about our experience, our story, and I can promote the living donors and deceased donor, and I can encourage their people to sign their consent, I do it. And all of this because I hope that one day we will be able to say, we found a cure, and we don't need dialysis anymore, and we don't need transplant anymore. And I say it's not an objective, it's a dream, because I know that it's quite a dream, but we have to dream in life. So to do this, that's why I get involved in a lot of fundraising activities. because I hope that research will bring a cure one day. And my other dream is to bring the World Transplant Games to Canada, and specifically to Montreal, because this is where I live. Because whenever these World Games happen, there is such promotion for for transplantation, for organ transplantation. It's a great event. It celebrates life, and it's a way to promote what the best that can come out of giving your consent to give your organs. So this is what I had to share with you today. I don't know if there are any questions.
Thank you, Sylvie, and thank you, John, for your great presentations today. We do have questions, and I know that we're a little short on time, so I am just going to quickly read out the first one. John, our first question is for you. What is the long-term risk of kidney donation?
Yeah, it's a great question. There's two ways to think about the risk. Sylvie highlighted the thing that many donors think about, which is a surgical risk, which is very low and very precisely known. It's 3 in 10,000. Be similar risk to getting an appendectomy or a gallbladder surgery for the donor. The difference being that that would be surgery that the individual would need, whereas obviously the surgery isn't needed. The long-term risks, Sylvie highlighted the fact that there's a careful screening process for donors. And with that, we know that the long-term risks of kidney donation, although it can happen that people develop kidney failure, they're low. The estimates are 30 in 10,000, but that's at 15 years post-donation. And you may say, well, how do you think about that? In general, that's lower than the comparable risk in the general population. So that tells you that with the careful selection processes, and as Sylvie also alluded to, donors tend to live healthy lifestyles after donating a kidney. And so I think that the risk is not zero, but it is a low risk. We encourage donors to live a healthy lifestyle. And more importantly, what we need to do in Canada is increase the follow-up of donors to make sure that donors maintain a healthy lifestyle, or if they develop problems as they age and get older, that they're quickly looked after. And we're moving towards doing that. Importantly, I don't think people should self-exclude them because they're worried that because they're worried that they might not be healthy enough. If you're thinking about donation, let the experts determine if you can donate or not.
And Tracy, if I can add to that, I'm not a doctor, but I can tell you that two things. Going through the screening process is almost a gift, because never in my life would I have dreamed of having such a physical exam of all my body parts. And secondly, after the transplant, I was approached by McGill University, and there's by a group of researchers who are doing a research on the impact on the blood pressure of living donors. And so every year I have to take my blood pressure for a week. They sent me a blood pressure machine at home, and I take my blood pressure 18 times during a week. I also have to go for a urine test and a blood test. So, I mean, you know, it's also a way for me to contribute to research. And so far, I see my blood pressure results. I think probably also because I've trained over the last 2 years, but my blood pressure is better than it has ever been. So, and I take no medication. I have no diet whatsoever. So, you know, yes, there are the risks, as Dr. Gill said, of the surgery, as there are in any other surgery. But after that, from a health point of view, no consequences for me.
Thank you, Sylvie, and thank you, John. Our next question, I think this is for John. Is there a priority for someone who was born with only one kidney?
The answer is no. There's people develop kidney failure for a variety of reasons. The only people who really get priority for transplant are children and people who otherwise cannot do dialysis because of some usually anatomical problem that precludes them from doing it. But otherwise, patients are not prioritized. The people that are prioritized for being highly sensitized, you can't really say that they get a priority because they're so disadvantaged in terms of getting a transplant. They still wait a lot longer than the average patient.
Thank you, John. Our next question, which will be the final one for today, is for Sylvie. And Sylvie, what would you say to other people who are considering living donation?
I would say that apart from giving birth to both my kids, it's probably the strongest human experience I've ever had in my life. I would do it without any questions again if I could. And I think it's, how should I say that? I get emotional when I talk about this, but you can do so much good to someone who's suffering and is not doing well with so little consequences on you that I think it's worth every second I spent on that.
Thank you so much, Sylvie. We're going to wrap up the question portion of today's webinar. And now I'd like to introduce Lydia Lauder, the National Director of Programs and Public Policy at the Kidney Foundation of Canada, to say a few words.
Thank you very much, Tracy, and a special thanks to Dr. John Gill and to Sylvie Charbonneau for sharing their beautiful stories and time with us today. And thank you all for joining us for our NOTDAW webinar. It's indeed a very, very special time of the year. And it was great that Dr. Gill provided some data to show the improvements in transplantation in Canada, but we still have some way to go for people waiting for a transplanted organ. He also presented a great overview of organ donation and transplant rates and innovation in deceased and living donation. Then we were joined by Sylvie, who shared her little family story and specifically her experience with donating a kidney to a son, Benoit. And yes, he is a handsome man, and we can definitely see the resemblance there, Sylvie. I'd just like to thank you for sharing your strength and your motivation and family story. And if anybody has any questions for the Kidney Foundation, please do get in touch with us. And remember, you can make a difference by registering your intention to donate your organs and speaking to your family and loved ones to make sure that they know and honour your wishes. Thank you for everybody once again participating in today's webinar.
Thank you, Lydia. And thank you for everyone for attending today's webinar, Kidney Transplantation and Living Donation. Once you leave today's webinar, you'll receive a survey on the presentation, and we'd appreciate if you could complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. And on behalf of the Kidney Foundation of Canada and our presenters, thank you for joining us today and have a great rest of your day.